Chapter 33, Trauma to the Head, Neck, and Spine. Before we get started, don't forget to like the video and subscribe so you get updates on all future videos coming out. Let's get started with a quick review of the nervous system here. Nervous system controls thought and sensation and motor functions. To do this, it's divided into two main groups. You got your central nervous system, which is the brain and the spinal cord. It's located in the cranium and the spinal column. Then you have peripheral nerves that send the signal from the central nervous system to the end organs, to the skin. It also brings signals back into the central nervous system from the sensory nerves. Neurons are those specialized cells that are made to transmit impulses through the body. That's what makes up our nervous system functions. As you can see, the core of the body, you've got the central nervous system through the cranium and the spinal column. Then you have the peripheral nerves. You've got the sensory nerves that bring sensation back into the central nervous system, and motor function nerves, which send signals back to the muscles and the other body parts to get things done in our body. Sensory nerves carry signals from the body to the brain, so it's picking up that end signal from the skin, the organs, telling us what to send back to the brain. Once the brain makes an interpretation, it sends the signal to the body parts to make things happen through the motor nerves. So it's sending signals out to the muscles to move. It's sending signals to the chest to cough, making things happen for us. And outside of the central nervous system, the peripheral nerves, you've got the autonomic nervous system, which does that involuntary control. It's like breathing, heartbeat, digestion. All those are controlled by the autonomic nervous system. Anatomy of the skull. You've got the cranium and the facial bones. Cranium is made up of multiple bones. You've got the frontal bone, the parietal bones, temporal bones, and occipital bones. As we get older, those bones fuse together into immovable joints. But as we remember from the pediatric discussion, newborns, they are not fused together, so they still have the fontanelles, which provide us access to some important information on the cranial pressure of the child. In the face, we have the mandible, maxilla, nasal bones, molars, and orbits. All very important. Most important part there are the mandible, maxilla, and nasal bones because they form the basis of our airway. The brain is held within the skull because they've got immovable joints. If you have any swelling in the skull, it pushes on the foramen magnum. That's where the brainstem comes out of the bottom of the skull. That causes some problems for us if we have any type of brain injury. The cerebral spinal fluid is what keeps the outer layer of the brain protected from shock. It provides a little cushion, gives us a way to move substances around through the brain. Problem sometimes happens when we get too much of it, increases our intracranial pressure, and causes more issues for us. So there's a picture of the bones of the head. Important to know where the frontal bones, the parietal bones, temporals on the side, occipital on the low back. Then you need to know your bones that form the airway, the mandible, the maxilla, the zygomatics, the nasal bones, bones that are helping us make sure we breathe adequately. The spinal cord is a bundle of nerves that go through the brainstem to the back through the back. It's a pathway of nerve messages. Then it ends at the bottom, at the base of the spinal column. You've got the cauda equina. It translates to the horse's tail. It's all the nerves coming out the very end of the spinal column. Tough, fibrous surrounding the meninges, or what surround the spinal column. That gives us protection from infection and keeps the bad stuff out of the spinal column. If you do get meningitis, it means there's an infection in there. Spinal column made up of 33 vertebrae stacked one on top of each other, interlocked together using ligaments and back muscles to support everything, keep everything in line. They each have a hole down the center which supports the spinal cord and gives its protection. It's important to understand that you have 7 cervical spine, 12 thoracic, 5 lumbar, 5 sacrum, and 4 coccyx. The coccyx and sacrum are fused together, which provides the back half of your pelvis. Lumbar is large, but it has no supporting protection structures around it. With the thoracic, you've got all the ribs and the shoulder blades that give you extra protection to those. And the same lack of protection exists with the cervical. Let's talk about the different injuries to the brain and skull. The scalp, if you've ever seen a scalp laceration, has lots of blood vessels. So they bleed profusely. Best thing about the bleeding on a scalp laceration is direct pressure stops almost all of it. Rarely do you have to progress to a tourniquet. So dress it as you would any other soft tissue injury. Direct pressure, apply a pressure dressing. The concern you might have is if there's a fracture, you don't want to put direct pressure on a piece that's going to be pushing into the brain cavity. So be a little cautious there, but as you need to apply direct pressure. Be aware that anytime you do get a laceration, there's potential for fractures. So use some caution there. If you have an open head injury, you can see the bones below it. If it's closed, you can't. So the closed head injuries are the ones we're more concerned with because you can't actually see what's going on underneath the scalp and into the brain cavity. So it's we have to do a little bit more assessment and have a little bit more concern. Any open head injury can have additional injuries underneath. So be cautious with those. Suspect spine injury or brain injury anytime you've got any type of head trauma. Here's a look at what a open head injury would look like. There's a fracture below that. You can see the parting of the bones down there. Be cautious when you're dealing with these because now you've got the brain exposed. 2 types of forces applied to get damage to the brain. One would be direct. The brain is lacerated, punctured, or bruised by broken bones or a foreign object. Some type of penetrating trauma goes into the brain and causes direct damage to the actual brain tissue. Indirect would be your concussions and contusions. The brain bounces around inside the skull and causes a bruise to happen or breaking of blood vessels, or it can have a concussion syndrome where it's just stunned from the impact. Traumatic brain injury is that large group that categorizes all of our injuries to the brain. These are short-term, long-term. It varies by patient based on the mechanism and their physical condition when we start. Concussions you hear a lot about in the news. It's the head is struck and force is transferred to the brain. So you've got the impact on the outside, the brain's still moving, and it impacts the inside of the skull. Anytime there's any type of head impact, all of our sports are starting to stop the play, get the person evaluated to make sure they're okay. So we're taking head injuries very seriously now. So if you are participating as a standby EMS provider at an athletic event, check in with the athletic trainers. Make sure you understand what they expect of you and tell them what you expect of them and work as a team so you can take care of our players the best we can. A contusion is a bruised brain caused by the blow forceful enough to rush blood vessels in the brain. So it's a bruise inside the brain tissue. We have 2 forces that we're concerned with. The coup is the direct side of the brain that's directly impacted. So you get hit in the frontal bone, you have injuries to the frontal lobes of the brain. But as that brain bounces off the front it bounces into the back, and the occipital bone causes damage to the back side of the brain. So that's the contra coup. So we're talking coup and contra coup injuries there. This shows the concussion. You've got the force applied to the frontal lobe. Then you may have damage to the back as it bounces around. TBI interrupts the normal function of the brain. You could have lacerations, causes a contusion in the brain. That's a long-term recovery process. What we're concerned about with the hematomas is where it is, subdural, epidural, or intracranial. The subdural, the blood collects between the brain and the dura. Epidural means it's outside of the brain's protective system, and you get the blood collecting on the dura, in between the dura and the skull. And the blood pools within the brain for the intracranial, intercerebral. This is the visual representation of that. You saw in the first one here, it's underneath the dura mater, and so that is subdural. It's underneath the dura. This is epidural. It's above the dura mater, and this one's intracranial here. As you get that hematoma putting pressure inside the brain or in the skull, it increases the intracranial pressure. ICP stands for intracranial pressure for when you see that. It's not a band. The IC builds up, brain tissue compresses, and you start having neurological difficulties. The other problem, as you increase the pressure in the skull, it pushes the brain towards the foramen magnum, putting pressure on the brain stem, which is our main center of control for our basic life functions. As the ICP increases, blood pressure increases because it's trying to get more blood to the brain that says, hey, I'm getting pressure and I can't get the blood I need. But it's putting pressure on the foramen magnum and the brainstem, so it's dropping the pulse because of the vagus nerve stimulation. So now we've got what's called Cushing's reflex. You've got a rising blood pressure and a slowing heart rate. That is not a common occurrence in shock, so if you see that in a person with trauma, you know there's a brain injury involved. Typically with a shock patient, you'd have a lowering blood pressure and raising pulse. So this is one of those clues that you need to pick up on and get them to the appropriate trauma center that has the capability of taking care of brain injuries. As the hematoma grows and swelling gets bad, you start affecting the breathing patterns. So tachypnea is just breathing fast. Cheyne-Stokes is breathing rapidly with periods of apnea. So you'll take 4 or 5 really fast, deep breaths, and then you stop breathing for 10-15 seconds. Central neurogenic hyperventilation is hyperventilation, but it's trying to get rid of the increased CO2 that's being produced. And so your brain, you're going to be taking really deep, fast breaths. Ataxic means there's no rhythm to the breathing. So there's no discernible, like once every 5 seconds, so every 6 seconds type of breathing. It's all over the place. As your brain gets worse, you go into corticate and cerebropostrine. The corticate, everything turns towards the core. So when you apply painful stimuli, the arms and hands and toes rotate towards the center line. Decerebral, when you apply painful stimuli, everything turns away from the core. And then signs and symptoms of rising ICP could be intermediate or delayed. So it kind of depends on what's going on with the brain and how much and where. You could have injuries that cause these visible bone fragments or brain tissue. You'll have altered mental status, deep lacerations, hematomas, depression, deformity, or swelling of the skull, severe pain at the site. Battle signs is the bruising behind the ears. This typically takes 12 to 24 hours to develop, so you need to be aware of that. It might not be a recent injury, but it's a really good clue that there's a problem. Pupils unequal or non-reactive to light. They'll have bruising around the eyes and the orbits. One eye appears sunken in if they've got a fracture on that one side. Blood flowing from ears, nose, or other fluids, so they got the CSF coming. You get personality changes. You have the Cushing's reflex, irregular breathing patterns, blurred or multiple image vision. They're seeing stars is something you hear about. Impaired hearing or ringing in the ears. They lose their balance. It's a real common thing. Forceful or projectile vomiting, and this is not just your minor vomiting. This one actually flows out really far. I've had them hit the ceiling of the ambulance before. Then you have to coordinate cerebroposturing paralysis on one side of the body, seizures, temperature increases, and the vital signs start getting worse. If you have symptoms of shock, that's not a common thing from a head injury. So start looking for the rest of the story on your patient. You won't have a low blood pressure and a high pulse from a head injury. If you do, there's something else going on. So don't get sucked into the tunnel vision of saying it must be a head injury here. Treatment-wise, we're taking standard precautions. Always consider spinal injury if you did something to injure the head, you did something to injure the spine. Maintain airways, monitor your patients carefully for their breathing. If you have to, put on a cervical collar, control any bleeding, and keep the patient calm. This is not one where you want to get them all spun up and nervous, so turn your lights down in the back of the ambulance. Maybe use that as a considering point whether you use lights and siren to return to the hospital, so that the agitating the patient can make things worse, so you might make some decisions here. Talk to them and provide support. They will be confused, so you need to make sure that they're being taken care of. Dress and bandage all wounds. Stabilize any penetrating impaled objects. Treat for shock if you have it. Watch for vomiting. Monitor vitals every 5 minutes. Use a Glasgow Coma Scale to help you with your neurological assessments. If you forgot what the Glasgow Coma Scale is, there's a video in Mod 5 supplemental. It's a really good video about the Glasgow Coma Scale. I'd look at it and just remember, and it's based on eye opening, verbal response, how they respond to your to your stimuli, and and you're grading it by what their response was. Same with the motor response. Trying to figure out what that is. If you do a Glasgow Coma Scale, do it on the way to the hospital. Don't take time on the ambulance or on the scene to make the calculation. It's going to help the hospital, but it doesn't help your patient if they're not at the hospital. Keep this chart with you in your notes so you can use it on your patients to make sure you're getting the calculation correctly. And remember, 3 is your minimum. So if you have a Glasgow Coma Scale of 0, we know you didn't do it right. Impaled objects, stabilize in place. Do not pull them out. You could cause more damage on the way out than they did on the way in. So leave everything in place. Pat around the object, stabilizing on both sides. Cut with a tool that does not cause the object to move or vibrate when severed. So somehow you got to get a tool that doesn't cut with friction or heat or vibration. So get with your local fire department to make sure they have some options for you there, and talk it out before you really need it. And if you're not sure on what to do, call medical direction and ask for help. They're always there for you. Facial fractures, usually direct impact, so protect the airway. Make sure that they can breathe, they're not bleeding into the airway. Because it fractured parts of the face, you need to be aware that it possibly caused brain or spinal injury, so be cautious of that one. If the mandible is dislocated, kind of support them in place and try to keep the airway open. It's a very painful injury for fractured jaws, so be supportive of that one. Be prepared to suction out the airway, use a jaw thrust, uh, stop the bleeding, support the spine. This may be a patient that you make that decision that keeping the airway open and placing the patient on the side is much more important than keeping the spinal column straightly aligned in a supine position and getting them to the hospital. So use some common sense and make some judgment calls here. Non-traumatic brain injuries, that's the other name for stroke. We've talked about strokes. Use the Cincinnati stroke scale. Figure out what's wrong with your patient and get them to the appropriate facility. Let's move on down to the neck. Just kind of review what's in the neck. You've got large arteries and veins that are close to the surface. That'd be the jugular veins that we're looking for distension, and the carotid arteries that we're feeling. Got some on both sides of the neck, so we do have a redundant system. But if you put pressure on both sides at the same time, you will close off the blood supply to the brain. So you got to be careful and creative on how you stop the bleeding. The other problem we have with the large veins in the neck is they are so close that they actually draw blood down into the chest cavity. So if they are open, they're going to draw air into those blood vessels and shoot that over to the lungs and become a pulmonary embolism. So that's a problem that can cause cardiac arrest, so we're going to try to prevent that from happening. If they have hemorrhage, we stop the bleeding first. Just direct pressure, push down, only using pushing on one side, try to keep the other side open. The next thing you want to do is try to prevent the air embolism. So that would be the applying the occlusive dressing or something to keep it from moving or sucking air in. So ensure the airway is open, put a gloved hand over the wound, put your occlusive dressing on. Make sure it's secured. When you're securing or putting the pressure on to stop the bleeding and securing the bandage with a bandage, I like to use a figure 8 process. So I wrap around one side of the neck, cross over on the shoulder on the other side, underneath the armpit, then cross back over the shoulder and come up on the other side of the neck. So I've got a figure 8, puts pressure on one side of the neck and uses the shoulder as an anchor point to give me the counter pressure. Then put the cervical spine protection on your patient and make sure that you're taking care of them. Let's talk about injuries to the spine. When you damage the bones, you have a potential of damage the spinal cord, so that's why we're cautious with them. We can have fractures with or without bone displacement. The spinous processes, the little processes that come out on the spinal column, they get fractured quite a bit. The problem we may have with those is that little bone fragment can work its way into the joint between each vertebrae and cause problems for us. You can have dislocations or distractions, muscle strains, or disc injuries. So that's the one from lifting incorrectly for too long. You actually damage the disc itself. Spinal cord is lacerated, contused, or impinged. Sometimes it's direct force. You cause direct damage to the spinal cord itself. That's usually penetrating trauma. Secondary injuries would be the bruising that happens after we have damage to the bones. The bones are separated and they cause compression of the spinal column. End up having hypoxia, shock, cord swelling, hypoglycemia. All problems that exacerbate the injury to the spine itself. When you do your assessment, always be aware that there's potential for spinal injury, and try to figure out if that's a point of concern for your patient. Use the mechanism of injury. Try to figure out if it creates enough potential for you. their physical condition. What are you finding? Do you see indications of spinal injuries? And progress like that with your patient. Different types of forces that applied that can cause spinal injury. You get the flexion and extension injuries, the whiplash. It's rear end collisions, front end collisions, where the head snaps back and forth and extends the neck and stretches it as it rotates down. Over rotation, they get the twisting motion on their body, mostly from sports. Compression, they dove into the shallow end of the pool. Distraction, but your hangings, some type of penetrating trauma, or bit improper lifting, lateral bending, or disc injury, all causes of concern for potential spinal injury. As we talked about earlier, the cervical and lumbar spine are the most susceptible because they don't have those supporting structures around them. Things that make a patient more susceptible to spinal injury: osteoporosis, the degeneration of the bones through the disease process; ligament getting stretched from pregnancy or patients with Down syndrome; and then if they've had previous spine injuries where they fused the joints together, makes it less flexible and more likely to get injured because it doesn't have that stability that a normal spine would have. Other high-risk MOIs, you've got falls greater than 3 feet or down 5 feet or 5 stairs. Some type of axial loading, putting pressure on the top of the head or on the feet. High-speed motor vehicle crashes, rollovers, ejections of the patient, ATVs, or bicycle collisions. All give you some extra concern for spinal injuries. Is the victim of a motor vehicle crash? Are they a victim of a motorcycle crash? Were they struck by a vehicle? Any direct injury to the spine or above the clavicle, so any type of head trauma? Was it a diving accident? Were they found hanging by the neck? Was it unconsciousness? Typically, shock doesn't cause immediate unconsciousness. So if the patient was unconscious, there's a potential for some type of head injury, which leads us to think there may be some spinal injury. Some low-risk mechanisms. Penetrating trauma is very low risk for us because if it does damage and it's over with. You may have some type of spinal fractures from an elderly. It's usually because of brittle bones and it breaks off the spinous process. It doesn't actually damage the spinal column. So look for the pre-existing conditions, try to sort out the mechanisms, and we're going to try to make some determinations here on how likely it is they have some spinal injury potential. So if you don't have a mechanism, you're going to look for the physical findings. You're looking for step-offs. You're looking for changes in their sensation, pain or tenderness. Things are going to tell us there's a potential for spinal injuries here. The way to know where the spinal injury is occurring is we use a called a dermatome. These are found in your books. You can look them up online. They're all over the place. It can pinpoint based on where the sensation starts and stops, where the the nerves come off the spinal column, and that can help you understand what the potential is for damage to the spinal column. Other indications: we're looking for paralysis of extremities, change in the neurological functions. They can't feel, they can't move a body part, pain with or without movement, tenderness along this spine or some type of deformity, impaired breathing. Priapism is a sign of a trauma injury because they lose control over the nerve endings that support the blood flow to the genitals. Loss of bowel and bladder control, same thing. You lose control, the nerve endings that go to those areas of the body, or just neurogenic shock. Well, we've progressed to in our system here is we use a system called Nexus Protocol. We're looking at ways to identify patients that do not benefit from spinal precautions. So then, the first thing you have to do is a patient conscious, alert, reliable? Are they a good source of information to confirm the information we need to have to make sure that they do not need any spinal precautions? If they're not reliable, we go with mechanism and treat the potential for spinal injuries. First, is there pain or tenderness in the midline of the spine? Are there focal or neurological signs and symptoms? Is there any type of distracting injury or circumstances? Maybe they're a second patient in a vehicle, then the other patient was killed. That would not make them a reliable source because they would be distracted by that information. And then with the pediatrics, we're really concerned about the MOI because that kills us a lot, and kids aren't the most reliable source of information, so we're gonna take that into consideration. What we want to do is have some good, thoughtful assessment to why we're doing what we're doing. Traditionally, we have taken a patient that's having pain in their back or potential for spinal injury, put them on a rigid spinal device, and made them lay flat for several hours while we did our assessments and x-rays and CTs of the scan. We found out that laying a patient on a firm, hard surface can create hypothermia from losing the heat into the solid object, or pressure sores from laying there too long. And it also exacerbates lung injuries. So we've got lots of issues with leaving them on there. So it started off with, as soon as you got to the hospital, the doctor would apply the Nexus protocol and determine whether to take them off the backboard and just leave the C-collar on until we could get x-rays. And we've progressed to the point where a lot of services are actually doing that before we even get to the point of putting them on the board. We consider the cot a viable source of protection for the spine. So you put the collar on the patient and have them lay carefully onto the cot. It gives them that protection we need. If you have spinal injury, lots of oxygen, ensure ventilation, treat for the bleeding, and get blood glucose. The blood glucose is going to help us maintain the health of the spine. So that's something we want to make sure our patients have an adequate level of glucose in them. If you're not sure, put them on the backboard. Do as precautions as you can. The spinal motion restriction prevents any secondary injury, so that's what we're trying to do. One thing we have progressed to is using vacuum splints to give us a little bit more cushion and a little bit more direct support of the spine versus laying them on a flat surface. Now we've got them on a curved surface that's fit just to their back. This takes into account the three centers of mass in the body: the head, the shoulder girdle, and the pelvis. So what we've done is try to secure these to the board with the vacuum splint to give you that natural curve shape, the S curve. Make sure that we're not moving the body back and forth. So it's called inline neutral posture. When we start treating a potential spinal injury, we're going to maintain the head first. You want to bring it back to a neutral line if at all possible. If for some reason you meet resistance, stop. Don't force the head to move if you don't have to. If it hurts, leave it where it is. Make sure we put the right size collar on the patient and that it does not obstruct the airway. If you put the collar on and they quit breathing, take the collar off. Make sure you're not causing the airway obstruction. Once you get the patient stabilized, you want to check the CSM, sensation, motor function, and circulatory functions, to make sure we haven't caused any more problems or we have a baseline to start our assessments on our patients. Once you get the head stabilized, then you put them on the whatever device you're using, whether it's the cot, the ambulance stretcher, the backboard, the vacuum splint, and then you secure them to the device. And then the last thing you want to do is secure the head to the device. We do the head last because if they do have to be rolled to the side, it's much easier to maintain two hands on the head than try to maintain two hands on the body while the head is secured to the device. It makes a better control there for us. We still use backboards occasionally for short transports. If it's a multi-system trauma and I just need one big splint, it's a good option for me. The other option, other patient you likely use it on is CPR because you need a firm surface. And it's also good for moving patients. A better device for moving patients that gives you the same type of support with less movement would be your combo stretcher. The ones that you can split apart, slide it underneath each side of your patient, and then put it back on. That way you don't move the patient around, and less movement is better for your patient. If for some reason your patient can't breathe laying supine, you're going to want to have them set up. Remember, breathing is more important than spinal restriction. Here's the discussion about the backboard. They form, or the vacuum mattresses, they form to the back of the patient. They're a lot more comfortable if you ever laid one on. It's much better than the firm, hard backboard. The problem you run into is they do absorb heat also. And if you get the patient to the hospital and you see a nurse come at them with a pair of scissors, get out of the room as quickly as possible because the vacuum splints are filled with tiny foam balls that are very staticky when they're cut. And as soon as they cut open the air mattress, it's going to be all over the place. So leave and warn them first and then leave. If the patient is seated, we have the option of using a extrication device. That is not our preferred method anymore. We just put them on a C-collar, try to hold their head neutral and ask them to stand up gently, turn around and sit down on the cot and lay down. You can also alternatively put the backboard on the seat underneath them, have them turn around and slide up the backboard. But either way provides much more stable support than our traditional extrication devices we used for seated patients. If they're in a supine position, you log roll them onto the board, looking where the voids are going to be, and then put padding down and secure the head last. Preferred method is use the vacuum splints, give them that extra support. If the patient is pregnant, you're going to want to raise the left side, or raise the patient to the left. So raising the right side and putting put a towel or a blanket or a pillow underneath that right side of the cot or underneath the board, so they kind of slide sideways. That's going to take the uterus and shift it to the side, and so it doesn't sit directly over the aorta and vena cava, causing more problems from being in a supine position. As we strap them in, we're going to make sure we have a strap across the chest, the pelvis, and thighs, the major body structures that are going to be moving, and then try to hold them in place there. If you're using a helicopter, make sure you use backboards that fit. Some helicopters are limited on size, so we need to be aware of what our services use. In our local area here, everybody's familiar with the helicopters. They have a room to put the size of backboards we carry, and so we don't have to worry about that. They do have specialized backboards for the lifeguards. All the pools around this area have them. They float. You can float them underneath the patient and then backboard them and strap them in underneath the water and then bring them out all as one. And then understanding the pediatric anatomy, remember the head is bigger, the occipital parts of the head sits a little bit lower than the shoulders. So we're going to put that little pad underneath the shoulders to keep the head in a neutral position. If they're standing, really simple process. Put the collar on, have them sit down on the stretcher. They could be supine or semi-seated. Both give them the protection they need. We've determined that the ambulance cot mattress is perfectly fine for giving that support to the spine. Here's a picture of applying the collar, and then we're asking the person to sit down and gently turn around to lay down on the cot. If the patient is wearing a helmet, we've got some decisions to make. First is, can we assess and maintain the airway with the helmet in place? If we can, then everything is good. If you have a way to remove the face portion of the helmet, that accomplishes the task of maintaining the airway without taking the helmet off. Again, going back, if you're working a standby at a sporting event that wears helmets, work with your athletic trainers to make sure they have the tools necessary to remove the face shields of the helmet so you can get to the patient. All your athletic trainers at football events carry the tools to take care of it. The modern helmets, it's just a pin to push in and it pops the face shield off. So you get that open up and you don't have any worries about it. If it hurts to pull the helmet off, leave it in place. We don't want to cause more pain. Another thing, based on experience, before you try to remove the helmet, remove the chin strap. It doesn't do you any good if you're yanking on the helmet and it's trapped around the bottom of their chin. It just causes a little bit more problems and pain to your patient. So you can leave the helmet in place if it's snug. What we mean by snug is like a high school or college level football helmet. They fit those to the player. Pee-wee families buy them so that they'll be big enough they grow into them, so you can spin them completely around and not be able to support them. So we need to make sure that they have a firm fit around the head. Same with motorcycle helmets. If it's fitting around the head and you can actually assess the breathing, you're fine. You can tape the patient to the backboard with a helmet in place. You may have to put a little padding under the shoulders to get everything right, or use a vacuum splint. If it interferes with your ability to assess or maintain the airway, doesn't fit right, or cardiac arrest, you take the helmet off. If they're wearing shoulder pads and a helmet, now you got to decide whether you want to take both off at the same time. Most football players, I've been able to get away with just taking the face shield off and leaving everything else in place. Hockey, you can leave the helmet in on your patient, except for the goalies. It's harder to get the face mask off. So if you're going to remove it, it needs to be two people. One to stabilize the head and one to pull the helmet off. So when you're taking the helmet off, like I said, take the chin strap off. Your first rescuer stabilizes the helmet. Second rescuer takes the chin strap off, puts the hands up inside the helmet. If you can remove the cheek pads, take the cheek pads out so you can get the helmet off easier. Stabilize the head from the inside with your hands, and then your other partner gently slides the helmet off and maintains the airway. As always, if you have any questions, write them down, bring them to class. Let's talk about them and let's learn more about head, neck, and spine trauma. Thanks and have a great day.